Hey everyone, and welcome back to the next ECG vlog. This will be ECG vlog number 4. It'll be kind of a spin-off from the last episode. And so in this question, we were faced with a 78-year-old male, sudden onset chest pain and shortness of breath. And the question was posed, what's the axis, and are you going to activate the cath lab for this patient? And so this is actually a right axis deviation for this patient, and we'll get into the STEMI situation here a little bit further down. But before we get into it, I kind of want to talk about what it means for the patient when they have a right axis, what it means for the patient when they have a leftward axis, and how does that help us clinically determine what's going on. So in a rightward axis, I essentially think of pulmonary hypertension. I try to think of acute situations in which there are increased pressure within the pulmonary circuit, and some things that come to mind, some chronic COPD, for example, a pulmonary embolism can do this as well. And basically we get this right ventricular remodeling because as the pulmonary pressures start to increase, our right ventricle has to generate a higher pressure than that of the pulmonary circuit in order for blood to flow down its concentration gradient. So in order for the right ventricle to empty, it needs to generate pressures higher than that of the pulmonary circuit. And the way the body does that is it will remodel or hypertrophy muscle mass in the right ventricle in order to effectively generate a stronger contraction. And so if more muscle mass is being recruited, we're getting more electrical discharge from the right ventricle, and that means that our axis is going to shift over to the right. And so some other conditions that can cause a rightward axis, sodium channel blockers, some toxic situations, or even acidosis, specifically hyperkalemia, both of those tend to cause a rightward axis. I'm not entirely sure as the underlying mechanism as to why, but they do tend to cause rightward axis, and the last being a right bundle branch block. On the other hand, a leftward axis, I kind of think of it along the same lines. Leftward axis, same thing. If we're seeing a high systemic pressure, then we're going to get that left ventricular remodeling, right? If we're seeing the systemic hypertension or high pressures within the aorta, then the left ventricle, once again, has to generate a higher pressure in order to push blood down its concentration gradient. In the same way, the body's going to do the same thing, remodel, hypertrophy the left ventricle. If there's more of the muscle mass being generated, then once again, our axis is going to shift over to the left. Some other conditions to consider if there's an acute leftward axis, some valvular disorders tend to cause the same leftward axis as well. If there's aortic stenosis or that aortic valve is not opening enough, then blood will remain stagnant and pool within the left ventricle, as well as mitral regurgitation or aortic regurgitation. If blood's not being emptied properly and blood is still pooling within the left ventricle, then the compensatory mechanism is to generate a more forceful contraction by remodeling and hypertrophying. So some other conditions that can also cause to keep in mind, left bundle branch blocks. Paced rhythms tend to have a left axis deviation as well, just because the guide wire tends to be transitioned down the left side of the heart most commonly. And then the other one is pre-excitation, or WPW, as that bundle of Kent or accessory pathway tends to exist on the left side of the heart as well. And so we ask ourselves, how is this clinically useful? How can this be used in an acute situation? And going back to our case, we're asking ourselves, is this a STEMI or no? And some things that caught my eye with this 12 lead immediately, I see some ST elevation in AVR and V1, some kind of rightward leaning leads. I see some global ST depression. And so the question was posed, is this a STEMI or not? Would we activate the cath lab? And it's always my recommendation that when you are approached with a 12 lead, to use a stepwise approach when you're trying to decipher what's going on. So for me, I always use rate, rhythm, and then when we get to the axis, I use the same method, lead 1 and AVF. And in this situation, it can be kind of difficult with the shading and the thumb method, because if we notice in lead 1, there's a prominent R wave as well as a prominent deflecting, negative deflecting S wave. And so when I'm faced with these situations, my general rule of thumb is that if the S wave is negatively deflecting and it's about equal to that of the R wave or greater than that of the R wave, then I would just call that a negative deflecting lead. And then meanwhile in AVF, there's no question that's a positive deflecting lead. So when we use our shading method, we called lead 1 negative just because there was a very prominent S wave, and then AVF was positive, giving us a rightward axis. And so in this situation, this is actually a STEMI mimic. This patient presented with a saddle pulmonary embolism, and this is a situation in which knowing the axis can kind of help us guide our diagnosis, because it is actually pretty rare for a STEMI to have a rightward axis. And so my general flow for this is, if I'm presented with the 12 lead that looks STEMI-ish, if it's pretty obvious and the patient looks bad, yeah, I don't think anybody would fault you for activating the cath lab. If I'm having doubts, I check the axis. If I see a rightward axis, I'll consider things like a pulmonary embolism or some kind of metabolic process like a toxin, like a TCA overdose, for example, that could be going on. So otherwise, this is a good situation, a good take-home point to remember, that identifying the axis can help decipher STEMI or not, just because it is pretty rare for a STEMI to have a rightward axis. So hope you guys enjoyed this quick episode, and hopefully we'll get another one out in the next couple weeks.